Good afternoon, everybody. Apologies for not being able to be there in person with you this afternoon, and thank you very much for coming to Conway. The next part of our presentation will be focusing on some of the future work that we're doing with public health, specifically looking at long-term condition management and risk optimization in patients with long-term conditions. In the UK, just a bit of background, most people over the age of 65 have at least 2 or more long-term conditions, including heart failure, COPD, diabetes, etc. And most patients over the age of 75 actually have at least 3 or more long-term conditions. Within the GP practice, and this is probably a slide that Joe has shown you already, this used to be a typical working week for one of our GPs. In the morning, we would see anywhere between 16 to 20 patients, and in the afternoon, again, anywhere between 16 to 20 patients, with 10-minute appointments each. We're often expected to manage patients with long-term conditions in these 10-minute appointments. And you can imagine that often patients don't come in wanting to discuss their long-term conditions, and they may have a different agenda, yet we have a series of metrics that we need to ensure that patients are optimized against, and often that takes up a majority of the 10 minutes. Importantly, it's not only the face-to-face appointments that we have to do on a day-to-day basis, but we also have anywhere between 5 to 10 telephone encounters in the morning and afternoon, possibly 2 to 3 home visits, and a huge magnitude of paperwork, including referrals, reviewing anywhere between 75 and 100 emails, faxes, blood tests per day. But on top of that, we have additional components to our contract which we have to deliver on. And ad nauseam, these would include the QOF, enhanced services, incentive schemes, child protection services, gold standards framework for our palliative care patients, ensure that we have appropriate information governance in place, engage with the Care Quality Commission, make sure that we have a patient reference group, undertake regular practice meetings, perform against our key performance indicators, ensure that we do some element of research and audit, review our prescribing habits, ensure that there aren't any human resource issues in practice, and also engage with the local medical committee, public health, and the CCG. You can imagine that it's a relatively chaotic situation, especially for smaller practices such as ours, and what we wanted to do was somehow step outside this chaos to ensure that we're managing our patients with long-term conditions who are questionably more vulnerable than the rest of the patient population, and practice proactive medicine, not reactive medicine. When you speak to GPs and nurses and colleagues who work in relatively deprived areas such as ours, they struggle with long-term conditions. They often say that it's an exhausting consultation, it can be demoralizing, and they feel extremely tired at the end of it. And often, it's, I think, a medical approach to long-term conditions where we're taking the burden of the condition on and not allowing the patient to self-manage or empower them to do so. What we wanted to do was change the ethos and how we practice at Conway, thinking about all of our assets at the surgery, not just the clinicians. We wanted to motivate our staff and in turn motivate our patients to focus on the compassion story, focus on autonomy, mastery, and purpose, give them some ownership over their long-term condition, start doing personalized targeted letters to patients, not only just saying, "Dear patient, surname, thank you very much for having your blood test done, please make an appointment to come in to discuss it," but giving them some information. "Dear patient, first name, thank you very much for having your recent cholesterol blood test done. Your total cholesterol is this, your target cholesterol should be this. There are a number of things that you can do to help yourself, including this, this, and this. If you would like some further information on how we can help you, please make an appointment to come and see us." As a consequence of just those simple targeted letters, I have personally found that compliance improves with medication and patients feel much more involved in their condition as well. The long-term conditions module outlines what we should be able to do virtually. By sitting at a computer terminal, I wanted to be able to have a holistic 360-degree view of what's happening at the practice, see patients that live on multiple long-term conditions, patients that we're sending monthly letters out to, inviting them to come in for our agenda, inviting them to come in for their heart failure check, their COPD check, their hypertension check, not necessarily focusing on those consultations on what might be bothering them. Also look at patients that are frequent flyers and frequent attenders, those that may be better off at encouraging them to self-manage rather than asking them to come in on a weekly, fortnightly basis. Using a piece of software, could we undertake a virtual review of some of their medicines that they're on, create a yearly plan for them to outline how many doctor appointments they would need or nurse appointments they would need, and create dynamic templates so to make the life easier for clinicians when they're undertaking some of the long-term condition reviews at the practice. The challenge with some of this is, how do you define risk? Is it just the number of registers that patients live on? If they are not on a register but they have a long-term condition which is not recognized by QoF, such as Parkinson's, liver disease, inflammatory bowel disease, or they are a very young child, how do we manage them? Is it just about looking at risk registers which secondary care provide, which are predominantly from the States, or can we use our primary care data in a way that hasn't been used before? Not wanting to add work, I think that there are a number of things that we can do in-house using the existing data that we have to optimize patient care. On the left-hand side, there's a series of metrics that we measure on a regular basis for our patients, and these are predominantly all modifiable. And on the right-hand side are a series of long-term conditions that are both related to QoF and outside QoF. Once you have a long-term condition, that's generally a fixed standard. You'll have that probably for the rest of your life. And the metrics on the left-hand side are ones that I can modify. If I challenge and change your sugar control, your cholesterol and blood pressure, chances are that I will improve your outcomes from diabetes. I will reduce the risk of blindness, reduce your risk of heart disease, and reduce your risk of amputation. If we think about the metric and the score that you can have within it, certain values are more dangerous for you to have than others, and we can perform a bit of a RAG rating on some of those metrics and give an individual an overall score. Using that score, what we're trying to do is establish a yearly plan for these patients and work out how many appointments they would need to see a doctor and how many appointments they would need to see a nurse throughout the year, and therefore plan out in advance what would happen at these appointments. And these appointments would be for their long-term conditions, yet outside this, patients would be completely free to book appointments for other things that might be bothering them, fungal nail infections, hair loss, etc. Things that really disturb them, but we can focus on their agenda and improve their patient experience of when they come to the surgery. This is what it looks like. On the x-axis, so across the bottom, are a number of different long-term conditions that patients may be living with, and on the y-axis is their overall score. What we can see is that there are some patients that just live on one long-term condition register, yet they're red rated, and those patients should come in and we should be doing something differently for them. And there are other patients that live on perhaps 7 different long-term condition registers, yet they're relatively well managed. Interestingly, when we've looked in this in a bit more detail, the patient who lives on 7 different long-term condition registers, including early dementia, cancer, heart failure, COPD, has a history that he used to live in America and was very, very conscious in how he used to utilize healthcare and healthcare resources, and has actually exceptionally well self-managed. And it's just unfortunate that he happens to live on 7 different conditions. Yet other people who just have one long-term condition are less well managed. And I think there is something that we can do for these patients, especially in the red ratings, to bring them in, offer them a holistic consultation, perhaps with a bit more time than the 10 minutes. We're thinking of running 20-minute long-term condition clinics to empower them and engage with them in a different way. Clicking on one of the columns, you can see each of the individuals. This data is anonymized, so you won't be seeing any patient identifiable data. And you can see what metric is making them fall or tip into the red category. You can group people together for, say, a diabetic clinic or a diabetic and COPD clinic, or you may even be able to identify patients that may benefit from prevention services such as the Greenwich Healthy Living Service or smoking cessation clinics, and bring them in for those specific clinics and undertake a virtual consultation. Thinking about resource utilization, we can see patients that have come in on a regular basis. On the x-axis here, we'll have the number of widgets of activity that occur in each of their journals across a period of time. We can see that there's some patients who are relatively well managed, yet they have at least 45 or more widgets of activity throughout the year, i.e. more than one time in the week they're having an interaction with healthcare, yet they're very well managed. This would be an ideal population to consider self-management with. Yet there are other patients that hardly ever come in, yet there is some metric within their journal which is pushing them into the red. And this may be a vulnerable group of patients, a housebound group of patients, or patients with mental health conditions, and a group of patients that we should just target in a different way. By no means do I think that we've cracked it, but certainly I think that we are at the beginning of a plan, do, and study act cycle. I think in the future we should be able to code the number of different hospital admissions that patients have they been admitted into ITU or HDU, quantify their length of stay, thinking about quality of life scores that they have, include local authority data, perhaps code local authority data within our primary care system in a different way, consider some social determinants of health, personal, household income, whether they're in social housing, what postcode they live in, thinking about incorporating some of the public health mosaic data. But I'm conscious that the only thing that we'll get as an output from this is a score and a point, but people aren't points and they're not numbers. And even Albert Einstein said, not all that can be counted counts, and not all that counts can be counted. I hope that we've done some way to demonstrate to you what we're thinking about doing, and hopefully we can move towards creating personal health plans for all of our patients, moving from a position where patients come in for an FP10, a green slip of paper, or a referral, to a point where the doctors are navigating and educating the patients in a different way, allowing them to feel much more engaged within the health service, allowing clinicians to feel that they can make more of a difference outside that 10-minute appointment by engaging and acting as navigators and overall improving the patient experience. Again, thank you very much for taking the time to listen to this presentation, and thank you again for taking the time to coming to visit us today. I think there is great value in continuing the work with public health, and I look forward for your support in this. Thank you very much.